Welcome, everyone. It is the top of the hour, so we will begin this webinar. Thank you so much for coming to today's Region 1 Insights webinar, Information, Safety, and Trust. My name is April Wright, and I am the Outreach and Education Librarian with NNLM Region 1. So just a few things before we get started. This webinar is being recorded and it will be available on the NNLM Region 1 YouTube page within a couple of weeks. And we are pleased to offer MLA, Medical Library Association CEs, and Certified Health Education Specialist CHEST credit for this webinar. Please be sure to fill out the evaluation, and we do value your input. A link will be provided at the end of the presentation. Closed captioning is available for this webinar. So if you cannot see the captions, you can go to the More button down at the bottom of your screen and choose Show Captions. So first, let me tell you a little bit about the NNLM. Once I figure out how to, here we go. The National Institutes of Health is the nation's leading research agency. And the National Library of Medicine is one of the 27 institutes and offices of the National Institutes of Health. It is the world's largest biomedical library and produces online resources like PubMed and Medline Plus. The NNLM is the network of the National Library of Medicine, and it's the outreach program of the National Library of Medicine, working to ensure health professionals and the public have equal access to health information. If you would like to learn more about us or find your regional medical library, you can check us out at nnlm.gov. And there are our 7 regions, and we are in Region 1. And just a bit about NNLM provides funding for health outreach projects, free webinars and classes, and access to a network of public and academic libraries, community and faith-based organizations, and universities. And NNLM Discovery is the podcast where we highlight funded projects. And that series is available wherever you get your podcasts or at nnlm.gov/podcast. And our initiatives, these are our list of our initiatives, and Medline Plus and PubMed, which are products of NLM. Now, on to our webinar. So welcome again, and I'd like to welcome our speaker, Dr. Amelia Gibson. Dr. Gibson is an associate professor and co-director of the MLIS program at the College of Information Studies at the University of Maryland and College Park. Dr. Gibson studies information marginalization, trust, and safety online and in health and learning institutions, libraries, and education, with a special focus on maternal health equity and local community access to information. Her research has received funding from the Institute of Museum and Library Services, the American Heart Association, the American Library Association, and the Agency for Healthcare Research and Quality. And I will stop sharing and turn it over to Dr. Gibson. Thank you.
Thanks so much, April, and thanks for inviting me. I'm really excited and relieved that the semester is over. So let me get my slideshow started. To share screen. Can everyone see my screen?
Yeah, we can see it.
Actually, now I can't see the chat, so I'm just going to trust.
Yeah, I got you on the chat.
Okay, thanks. Okay, so actually, I have a second screen, so if you see me looking up to the right, that's what I'm doing. Okay, so today I'm going to talk about safety, information, trust. The context that I'm talking about is a study that I worked on with some collaborators at Chapel Hill, Ohio State, NCA&T on perinatal care. Actually, the project itself is focused on postnatal care, but the data addresses perinatal care. But it has a lot of implications for the ways we understand patients and information seeking and information behavior and defensive information practices sort of across the board. And so we'll get to all that. A little bit about me beyond my short CV. The work that I do focuses on how we understand people's information and data needs and practices, right? So people's has a big caveat there. Sorry, I'm going to move my screen so I can see the whole thing. When I say people's, I mean individuals, I mean communities, I mean, we talk about people in lots of different ways in information science, and that's my perspective, is information science. I work with clinical colleagues who work in healthcare systems, but I'm not a clinician and I'm not an MPH. And so I want to make that clear. My focus is on the information practices, information needs, and how we build systems that meet those needs or don't meet those needs. That brings me to a lot of work in information literacy, information access. The work that I've developed is work on information marginalization, and I'll define that sort of towards the end. And it's now pushed me at this point in my career to examine this other question in red, right? So how do we understand institutional processes, institutional policies, norms, and goals, and how can we build systems that meet those goals while we also meet the needs of individuals who use those systems? How can we make those systems safer to use? How can we make them more accessible, et cetera, right? So that's my main focus. So before I get into the studies, I want to do my thank yous and my acknowledgements. This project was funded by AHRQ. The funding, the specific study, AHRQ was not involved in the data collection, analysis, or interpretation. The authors who you see here, myself, Jasmine Garland McKinney, Karen Sheffield Abdullah, Allison Stubbe, and Kristen Tully are solely responsible for the contents and findings, et cetera, et cetera. But we want to thank AHRQ for their funding and their support of the patient safety libraries, patient safety learning labs as they were going on. I think the programs ended in 2024. So if you're interested in the paper that I'm going to be talking through today, there's a link there. There's a QR code link to it there. So a screenshot might be helpful. Okay, so this particular model that I'm talking through, the particular study, took place within the context of a much larger study on patient safety within postnatal care. The research team was one that was extremely interdisciplinary. So the three PIs were Emily Pattison, who was an industrial engineer at the Ohio State University. Allison Stubbe, who is an OBGYN at UNC, and then Kristen Tully, who is a medical anthropologist at UNC. I was at the College of Information. You can see me in the middle there when I used to have my straight hair. I was at the College of Information at UNC then, and I've since moved to the College of Information at UMD, University of Maryland. Within this group, there are journalists, there are nurses, there are marketing people, there are all sorts of folks in here. And so it really is this sort of broad interdisciplinary look at the ways that postnatal care, mother-baby recovery, care transitions, and clinical care are provided within that setting. And my work, the sort of information-focused work, is just one tiny corner of this huge project, right? Context, again, at the time, why? So the study was funded from 2019 to 2024. The proposal, we talked a lot about why. And I think, I'm not sure if we all know the whys, but there are very steep disparities in care and in outcomes for mothers within US birthing systems, right? So Black mothers have very high rates of maternal mortality compared to the rest of what we consider to be the developed countries, which I think is a problematic framing anyway, but comparing to our economic peers, we have really high rates of maternal mortality. things that we think of, we generally think of as protective for care, for outcomes, are not generally protective for Black women specifically. We have similar issues with care for Indigenous mothers. So some of this was the motivation for the study. Thank you, April. Okay, so this in this talk, I'm going to focus on one part of a study that came out of AIM-1, where we were analyzing current processes, current procedures within the hospitals that we were studying for maternal infant dyadic management. So the two of the mother and the baby as a pair, right? Management and evaluation during the postnatal unit stay and during discharge transition. So the ways that people interacted with them while they were in the hospital in the first 48 hours. And then if they, well, in all cases, discharge transition, but if they were there for more than 48 hours, we would talk to them, interview about that post 48-hour period. In the first 48 hours, we recorded most of the participants in their rooms with consent. There were chart reviews, analysis of the EHR. We had folks, we had researchers who were shadowing and observing nurses, OBs, medical students on the floor, on the labor delivery floor. We did Vocera analysis, so use analysis, when and how nurses and OBs were using Vocera, the communication system that doctors wear on their lapel in the hospital, and how that either interrupted or facilitated or whatever it did for communication among colleagues, but also between the healthcare team and the parents, the moms, and the support people in the hospital room. And then the biggest, most time-consuming part of the study was the in-room filming for the first 48 hours post-delivery. So this study focuses specifically on interview questions, 3 interview questions and 1 follow-up that we did with participants. One was, what does safety mean for you in the postpartum period? So not necessarily what makes you feel safe, but how do you define safety? 2, in what ways do you trust or distrust your healthcare providers? 3, do you think that your healthcare provider trusts or distrusts you? And then as a follow-up, we asked, how do you feel about sharing personal information with your healthcare providers? One of the things that we saw very quickly coming up in the data as we went through, we did reflexive thematic analysis. So one of the things we saw coming up in the qualitative data was conflicting definitions of and values around trust and safety when we examined the definitions that were given by mothers and then definitions that were given by healthcare providers. There were very different meanings of trust, very different meanings of safety. We saw conflicts around informed consent, specifically, information access, and then the definition of respect, like what constituted respectful care, was also very different between patients and providers. And then definitions of quality care were different. So here's an example. One provider saying, like I speak some Spanish, maybe it's broken Spanish, but it's enough to communicate, right? And again, thanks to my colleague Kristen Tully at UNC for creating this slide. This was a discussion slide that we used for the team as we were talking about, so who gets the choice to say when communication is enough, right? Who gets to say that this provider's broken Spanish is enough to communicate? Who gets to say when something is important enough to call in a translator, right? There were a lot of differences in perspectives between the patients and the healthcare team. And so we found that a little bit alarming. So some meaningful and alarming differences, other meaningful and sometimes alarming differences that we found in experiences specifically of Spanish-speaking mothers. We did not expect this, right? We were going in with this sort of statistical understanding of the differences in care for Black and African-American mothers and Indigenous mothers, and we saw these very striking differences for Spanish-speaking mothers. One was the availability or inavailability of translation services and the lack of a right to decide sort of when those services would be provided. Again, this question of what's important enough to start the translation conversation. I'll show another example of that. Two was an alarming lack of access to food for a lot of mothers who could not, who didn't speak Spanish because they weren't aware that they could order food. No one thought to tell them, and they didn't know how to ask, right? And so what we would see on video was mothers speaking to their support person, their significant other, their husband, whoever it was in the room, saying, you know, I'm hungry, and the two of them talking about how to get food, and that never being resolved. And so that was one of the things that we had to sort of stop, not stop the study, but we had to intervene in the middle of the study because people weren't getting fed. They would be there for 2 days and not get fed. And so that was a pretty early on concern that had to be addressed in real time. 3 was differences in definitions of informed consent. So talking to an English-speaking partner to get consent and not explaining what's going on to the Spanish-speaking mother. Things like that. These were kind of situations that we saw. And then we saw a trend of evaluation for immigrant mothers specifically, evaluating care explicitly in comparison to care that they had received in another country, right? And so in a couple of cases, we had moms who said, oh, well, everything is great here because when I had my baby in such and such country, they didn't even blank, 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 right? And so the things that they were comparing weren't necessarily to the standards that the hospital should have been using to provide quality care, but when we asked about safety or their experience, the mothers would say, oh yeah, it's great because someone asked me what I wanted for lunch, or you know, whatever it was, right? That was not necessarily to our expected standard of care. So because of these differences, we actually increased the sample. After the first 40 participants, we went and looked for 6 more participants who were primarily Spanish speaking, and I think 3 of whom came from another country, so that we could get a little bit more data on those comparative experiences that people were having. Okay, so this is an example of that informed consent issue. This is one of the screenshots from the hospital. Here you have the nurse administering a vaccine. I think there's a varicella vaccine at this point to a Spanish-speaking mother. The nurse talks to the partner, the support person in the room, and asks, is this mother going to get this vaccine? And doesn't give the mother any information about the vaccine. The partner turns to the mother and says, chickenpox, and the mother has a bunch of questions about whether the baby's going to get it, and does it help the baby, and the partner turns back to the nurse and says, yeah, she's going to get it, and then the nurse gives her the vaccine. Right? There's no vaccine information sheets. There's nothing, none of the things that we would usually expect when giving someone a vaccine, right? And so the informed part of informed consent was often found lacking. So we collected the data. We had, I want to say, 5 researchers analyze the qualitative data, and we came up with this list of 5 different definitions of safety. Again, this is qualitative data, so co-construction of data really is something that is a conversation between the researchers and the data, right? There are many ways we could have organized some of these things, but these are the themes that we saw as the most the groupings that we saw as making the most sense over time, right? So we've presented and had discussions with colleagues about this over a couple of years now, and this is how we're sort of grouped it in a way that we think makes sense to our healthcare colleagues, right? So one is access. Safety requires access to information and knowledge. And that showed up as provider knowledge, right? So I'm safe if I think I have a good doctor, if my doctor knows what he's talking about or she's talking about. Two is that you have access to tools and technologies. One that I always remember is a mom and her sister holding the baby and saying that they were holding the baby. And the mom said, my sister said, I don't believe that this little bracelet, there's a bracelet they put on the baby that is meant to keep the baby on, not keep the baby on the ward, but alarm if the baby is taken off the ward, right? To prevent kidnapping or removal of the baby from that floor, right? The sister saying, I don't believe that this little thing does anything. I don't know if it keeps the baby here at all, right? And the mom saying, no, don't touch it. You're not supposed to mess with it. If you take it off, the alarm will go off in the nursing station or something. And the sister's like, no, there's no way. I don't trust it. And so she pulls off the bracelet on purpose, and a nurse comes rushing in. And that story always strikes me as one of those examples of what we consider to be bad behavior, quote unquote. Like it's one that literally breaks the system to test it, right? But we saw lots of little testing behaviors that were really important in terms of reassuring the moms that they actually were safe, right? So these actions, giving them access to knowledge about where their baby was. I guess that fits in number two, but these are the things that tell them where their babies are, things that facilitate sharing of information between nurses and parents, or nurses and other nurses, or the dry erase boards, et cetera. These were all seen as tools and technologies that were important to safety. So having access to that information was important to themselves, not just knowing that their doctors had access, but that they had access to what they needed to know about these things. And then supportive information seeking and sharing practices. So things like, does my doctor answer my questions? Do they offer patient education? These were considered access, forms of access safety. Number two is action. So the testing behaviors that I just talked about was one of the actions I would consider to be a defensive information behavior, but practices and protocols that engage things like infection control, so hand washing when you come into the room, responsive actions. Those were all considered actions that were key to safety. So safety actions, so safety behaviors were a way of talking about safety. Number three was autonomy. So bodily autonomy, informed consent, informed refusal, and then privacy. So their personal control over their personal information was important, even if they wanted to share it with their provider, right? So they still wanted to say whether they could share it or not. And then fourth is sort of the thing we think about when we think about safety, the feeling of safety, right? So safety as emotional, the sense of peace that people had, not needing to worry, the sense of support, so knowing that they are supported, and then confidence. So that kind of goes back to that idea of belief in provider knowledge at the top, but there was this sense, like the feeling of it, that people just described as sort of different than access. And then finally, there was a summative assessment of safety. And here is where we found a lot of conflict that was a little bit concerning. So even if people described actions not being taken, bodily autonomy being violated, questioning provider knowledge, I'm just looking at the chart, people questioning provider knowledge, you would hear people then say, but at the end of the day, we made it out alive, right? The summative assessment, like considering everything, they did do this thing where they didn't ask me if I wanted this vaccine, and like I thought we were going to die, but we didn't. So at the end of the day, I guess we're safe, right? And we would see people have this real conflict in the way they talked about safety when they got to this summative assessment. The thing that was a little alarming, though, in our comparisons between provider and parent definitions of safety, is that summative assessment was where a lot of the providers began. It was, everyone, there were no injuries reported, no one died. And so at the end of the day, everyone was safe. Everything was fine. So that was a concern for us. We saw summative assessments as being defined by time, right? So some people would say it's fine to have a little bit of pain or fear or whatever it is, as long as in the long term, everything worked out fine. And then another thing we saw was that we would see some people focus on the effort that the team put in while ignoring their own experience of safety or lack of safety, right? So they would say, I was scared of this thing and it felt terrible. And I didn't feel like, one woman said, I didn't feel like this was safe, but the team tried so hard. The nurses tried so hard. And so I guess I was safe because they tried so hard, right? And so this space of the summative assessment was one that we thought was very kind of fraught. I will say one other thing. We often measure that summative assessment, right? And so that's something that we had some concern about. People measure at the end, and that's what they often put into their surveys or their forms, is that sense of summative assessment. So just by way of example here, a quote. This person said, when I got to the OR, I remember that I was really scared, and my husband wasn't there to give me that feeling of safety, right? So 1.1 is that often significant others, husbands, family members, support people in the hospital were the people who gave a sense of safety. In some cases, and again, we're going to remember that this was during COVID, right? So, or a little after COVID. And so people were also considering the potential for infection and knowing that the person who came with them from home could help sort of monitor all these behaviors, these protocols, these things was important for some people's sense of safety, right? This person said there was no one of my family that I recognized around me, but there was this nurse in the OR, and I explained to her, I don't want to die in here by myself with my family, and she consoled me and said, made me feel like I'm going to hold your hand and you're going to be okay. And it's okay. And I know it's scary, but it's okay. And I'm just remembering that part right now. So this kind of ties in several of those definitions of safety. As a practice, this person is providing emotional security. They are, let's go back. It's the affective experience. And she does do a bit of summative assessment, but she goes back and she does talk about like how she felt in the moment, right? It's scary, but it is okay. And she, at the end, she remembers that this person was there to provide that emotional support. Here's a different example, a not so positive example. This person said, I woke up in the middle of the night and I was awakened by two nurses literally getting ready to, I don't know what the injection was. I guess it was for I don't know what. I can't say specific on what the injection was. I was asleep. Nobody woke me up to do it. And they were getting ready to do it. And I woke up because I felt people touching me and hearing them talking. And that was the only way that I knew. And I made sure that I told the doctor about it because that should never, ever happen. So the other thing we asked about was trust. And we came up with 3 different examples of trust. And as we did that, we realized that there were these 2 different definitions of safety, sort of competing definitions of safety that were coming up in our definitions, right? So access, action, autonomy, effective experience, and summative assessment. But within each of those definitions, we are seeing both positive safety. So the idea that safety was something that people could define for themselves and something to strive for, and negative safety, which was the idea that safety was about avoiding injury and avoiding harm. So if you're describing your sense of safety, and you're framing it in terms of negative safety, you have to prove that your safety was violated, which is different than describing positive safety, because when you do that, when you're describing positive safety, what you're doing is trying to demonstrate that you met a goal of yours, right? So one is about I would say when describing negative safety, people felt the need to have like indisputable proof that this thing had occurred that could not have been their fault. And then if the doctor, they were, I guess it was as if they were afraid that the doctor would like hear that they talked about this thing. And so then they would have to like prove somehow that they didn't, that they had a right. That's it, that they had a right to feel unsafe, right? It was really interesting in terms of interaction just in the interview process. So we use that framework of positive safety and negative safety to frame our discussions of trust, right? So trust, the three breakdowns of trust we had were trust as confidence, trust as expectation, and then trust as submission. Trust as confidence was by far the most common definition of trust, framing of trust that we saw, right? So confidence in your provider's expertise, confidence that they have good skills, confidence that they're an authority on the topic, right? So I believe in my provider, I trust them because I think that they're good at what they're doing. I trust that they're knowledgeable. I trust in their competence, right? And what we saw in terms of behavior that they described was a willingness to share information, willingness to ask questions, willingness to challenge their provider, because they were having open communication with this person. Bilateral communication was more common. They had better perception of their provider's trainings, and they had a better sense that their provider also trusted them, right? The second definition we saw, which was less common, was trust as expectation of a specific behavior. So I trust that they will do this specific thing. And that was very transactional. Like we would see that people would say, I'm going to give them the information they ask for because I trust that they will use it for my care. That's not necessarily, I trust in them implicitly, but I trust that they will do this thing that they're required to do per their legitimate authority, right? They will respect their oath. They will fulfill their job, their job requirements, right? And it wasn't necessarily negative, but it was just more transactional. And then here we had a little bit of concern. We saw a trend of trust as submission. Now, this was a smaller group of people, but it was almost completely made up of Black and Latina mothers who were Spanish speaking. I didn't have a choice but to trust them with, and trust was about submission or sort of like one mother said, of course I had to trust them. I was going to be unconscious, right? Like what else could I possibly do, right? I had to trust them with my care. So this wasn't necessarily about confidence or even expectation. It's, I have no other choice. I have no option. And so I will just have to accept what comes, right? So it's more acceptance than trust. This often was paired with actually a sense of distrust, some skepticism. We saw people withholding information, seeking other information sources, or just disengaging from care altogether. So what does this do for patient behavior and care? Like, what do these definitions matter, right? We had about 65, this wasn't a qualitative study, but I would say about 65% of the participants said they felt fine sharing information with their providers. Most of them directly tied trust in their healthcare team of some sort to this idea of sharing information as a motivator for sharing information. Most people assumed that the information that the provider asked for was relevant or needed for some specific care purpose. So whether it was to inform their current care or their future care, a lot of people talked about having a complete record for emergencies because you just may never know what, right? What could happen. They expected that it was used to ensure continuity of care or to monitor chronic illnesses or in case of complications. But only half said that they always shared their, quote, full story with their providers, right? And I think that at the same time, we were doing some work on collection of social determinants of health data, and it was not clear to us that patients understood the difference between collection of that data for providing social services and for providing care, right? And so there was some question there about informed disclosure, not necessarily informed consent, but informed disclosure of personal data for other uses. Some of the defenses, so the work that I do has a lot to do with information marginalization, which is about the ways that institutions create information systems that force people to engage in defensive information practices. So it's not just that people don't have access to information, but we create systems that create lack of safety in some way that makes defensive or self-protective behaviors the rational choice, right? So the defensive information behaviors we saw were withholding information from providers, dissembling or not telling the truth, testing behaviors like the one we saw where the woman pulled off the baby's bracelet, the security bracelet, building community and lateral information sharing, gossip or informal information sharing with other mothers, seeking information from less reliable but quote unquote safer sources, and then disengaging or opting out of care. And we think about some of these behaviors as negative, but they're not all negative. And we often think about these behaviors as irrational because we tend to be on the institutional side when those of us who work in institutions tend to look at it from the institutional perspective, right? But from the information perspective, these are not necessarily bad behaviors. They are just rational or irrational behaviors. So if we want to meet these goals that we have stated, here we have the Healthy People 2030 goals related to to health literacy. I think some of this requires that we understand what creates this, right? Like what information structures create these information behaviors. Some of the goals that either don't have enough data or have seen little or no detectable change are increasing the proportion of adults with limited English proficiency who say their providers can explain things clearly. We saw that was not the case for many of the participants in our study. Increasing the proportion of adults whose healthcare providers involve them in decisions as much as they wanted. Increasing proportions of adults whose healthcare provider checked their understanding, and decreasing the proportion of adults who report poor communication with their healthcare provider. There are several cases in which providers did not talk to the patient at all, or when they did, it was only after they had decided that translation was necessary or important, and the patient didn't get a chance to make that decision. And so we have a long way to go, right? Just as a matter of theory, those of you who are interested in theory, this is a really good example of testimonial injustice, right? So our measurement of these things, the ways we measure safety, often don't take these different patient definitions into account. And so I'd like us to pay attention to, it's one thing if we say, we don't know, we didn't realize, but our study was not the only study to find these things. It was just the one to pull them sort of all together into this model. And so I think we're at the point where we're making choices about how we deal with, how we create institutional health information literacy, right? Or organizational health literacy. And I think we have choices to make. And that is the end of my presentation. I am eager to hear questions and to have some discussion with you all. Thank you.
Hey, thank you very much, Dr. Gibson. This is great. So far, no questions in the chat. Please do put questions in the chat.
I went kind of fast, so I was trying to get through so that we had time to talk, but I can, if anyone wants me to expand on any specific parts, I'm more than happy to. I want to make sure we got through the whole thing.
Okay, great. I would like to start with a question in terms of the defensive behaviors. I'm wondering, it's like, do you have any suggestions for how folks who are kind of working in health spaces, working in libraries, making information available. And I know that that's in a care setting,
Mhm.
right? How do we kind of empower people uh, to get the information that they need, but still kind of work with, within their self-protective behaviors? Because
Yeah, this is a really great question. So I start off by saying I'm interested in the two sides of this. The perspective that is primarily the not patient, the person, right? Because people are not patients. Patients are people, but all people are not patients. But also the implications for institutions, right? And I don't think the implications are the same for different kinds of institutions in this case. I think if you're on the clinical side, if you're the healthcare provider, it looks like one set of practices. And if you're a librarian, if you're a person out in the community, if you're a person who's helping people who are seeking their own information, I think that looks different, right? I think um, a librarian, someone out helping someone in the community has a lot of room to work within these behaviors, right? Withholding information, I think we have responsibility to help people understand their rights as patients and to help them understand how to process information, to understand what their privacy rights are. So that's from the institutional perspective. I think people will go to other information sources. So actually have a question for like who's in the audience. I think that would help me tailor how I answer this question. Um, because it looks different for someone who is a medical librarian supporting clinicians, right? As opposed to someone who is, right. So you're an academic librarian for nursing. Okay. Hospital library. Okay. So if you have someone coming to you asking for help, well, let me think about it. And so here's where I find the gap to be. A lot of our medical librarians are primarily supporting clinicians, but not necessarily with how to engage in information sharing, right? Um, our public librarians are not necessarily helping people. I mean, they do help people with health information, but not necessarily at the same level, right? And so there's this gap. There's this gap. So if you're a person, who's the person who helps someone who does not trust what their clinician's telling them and wants to help and wants help in understanding their care options? Is there someone who's meant to help that person? I don't think so. Right. So nursing students, your nurse might, so your nurse might be able to help you with some of that stuff. Yeah. So this is part of our problem. This was part of the problem we identified, that there's no information professional whose job it is to help the patient. Primarily information professionals help the clinicians while they're in care. Yes. So the question is, are there any existing interdisciplinary programs between information literacy efforts and hospital patient advocacy programs? Okay, so Joelle, you said you are a librarian for primarily public mental hospital, and 90% of your work is with patients. That's wonderful. I think if you're in that position, then you have a lot of power to help people seek high quality information in a context where they don't have that fear of backlash. One of the things we saw was that for people who did not have a good working relationship with their provider. The people who were in that, let me go back to the slide. So people who were in that trust is confidence often had a really good relationship in terms of asking their clinician questions, challenging the context that the clinician, the assumptions of context that the clinician brought to their diagnoses or to their recommendations. When they didn't have that, when they did not have a clinician who was engaging in patient education, who wouldn't answer questions, for a lot of people, there was not that person who could help them answer questions. And so if we could create more spaces where people could ask those questions, get those questions answered, express doubt, engage in testing behaviors, or even seek information without having to disclose a lot of information, because just the act of seeking information, if you are undocumented, or if you don't speak English, right, even in some places, is not necessarily as easy or as safe for everyone as it is for those of us who speak English, then you have a lot of power in that space. Yeah, so public librarians are more likely to get more medical information from people seeking information. That's a good point, April. Even in our conversations even in the interviews and our conversations with the participants, there was a lot of checking to make sure that none of what we said would get back to their providers, right? And so there's a real fear for some patients, for some groups of patients, that even asking questions or pushing back, the things that we think of, the engagement that we think of when we think about reference interviews, for example, that is a dangerous endeavor, right? If you're in a clinical situation. And so having spaces where people can like kind of tussle with questions, I think is important. I think helping clinicians understand that information seeking behaviors or information testing behaviors or defensive information behaviors are not necessarily bad behaviors, but they are often responses to sort of an institutional structure, right? I think that's important for avoiding not just a perception of bias, like clinician bias, but actual clinician bias, right? So it's not that this person doesn't know how to behave, it's just that they want to know where their child is. They want to know, they want to know the things that you might think only you need to know. Understanding that for some people, community is extremely important. Having a support person is extremely important. But that you should still also talk to the person who is actually the patient. That's important. I'm trying to think of other answers to your question. Does that answer your question, April? I feel like there's no like perfect answer, because part of what we identify was just a hole, like a gap, right?
Are you thinking about Anne's question as far as the programs to information literacy efforts?
No, your question about how the folks who are in libraries can help with this, right? And so part of what we identified was that, that there aren't many libraries where patients get to talk to someone who isn't directly responsible for their care.
Right. Yeah. Yes. So yes, you did answer the question.
Yeah.
And just adding, I was going to put in the chat, doulas. Doulas are, working with doulas. They are.
So my current postdoc is actually, she's not an information person. She is she does maternal mental health work. She's a licensed clinical therapist, counselor, licensed clinical therapist. She has a PhD. She is also a doula and a lactation support. She's like licensed in lactation support, North Carolina, right? And she's found, one of the problems she's found is the lack of support that doulas get from clinicians in that space, right? They could fulfill this really important community health an information space, an information role, but they have to sort of be afforded that privilege by the care team, right? And that isn't always the case. So I would say, to Anne's question, it's not necessarily that interdisciplinary programs between information literacy folks and hospital folks have been the thing, as much as the hospital folks sort of need to make space for the community health workers, the doulas, like folks who provide informational support, but don't have authority to. It's the authority question, the authority to direct care. Okay, so you said there's a fairly recent, Anne says there's a fairly recent initiative for Appalachian public libraries to become embedded in health information response regarding the opioid epidemic. This is such a stigmatized area of health, possibly a point where this could go as well. Yeah, I think that's a really, that holds a lot of potential. So I think, so not that maternity is stigmatized, but I think any space where there is this power imbalance between providers and patients, for the maternity care situation, I think we saw this at its sort of worst between immigrant mothers and providers, but I could totally see a sort of similar power imbalance between folks who are seeking substance use treatment and healthcare providers, right? So there's this fear of not just reporting, but also social services coming in and posing a threat to other children in the family, you know, and so any space where there is that imbalance and this fear of like reporting might benefit from this third party like information support, I think. Thanks for that, Anne. Do we have any other questions or comments? It is a little weird having like I'm the only person with a voice and just reading the text. So I appreciate the written questions, is what I'm trying to say.
Oh, this is good. There's no cacophony of sound, so.
Lily says there's an amazing season of the podcast, Something Was Wrong, about unethical birthing center practices, including a patient of color with a particularly awful racist experience. If anyone wants to get mad and sad, take a listen. I will definitely take a listen, but I will also say there were so many concerning situations that we uncovered. Some of that, as you saw, the food one was like very immediate. But another concern that one of our nursing students, PhD students, uncovered in her system as she was doing her part of this was that I think Medicaid started covering IUD implants while we were doing the study. And in the hospital she was working in, well-meaning providers would offer these implants without proper translation, without proper education. The mothers would say yes because they were trusting, quote unquote, trusting their doctors to do the thing that they should do for them. The mothers were not getting proper information about what they were getting, and it wasn't clear that they knew that they needed to follow up, that they knew that an IUD was a form of birth control. It just wasn't clear that they knew that they had to be taken out at any point. And so again, that was a situation where one of the PIs had to have a conversation with a colleague at another institution to express concern about the way that was being handled. So there are a lot of these practices that sort of appear to be well-meaning and well-conceived, but at the same time when you consider the information and the informed portion of the informed consent, don't turn out to be what we want to see ethically, right? We'll ask, are there any plans to pass these study information or findings to other hospitals or medical libraries? I will say that it was published in Social Science and Medicine. And so this is one part of, again, a very big study that had several papers that came out of it. But if you're interested, you can find the study findings here. And part of that passing along is having talks like this one, I guess. Thanks, April.
You are welcome. And thank you so much for your presentation. This was great. And thank you everyone for coming. And I have put the link, there it is, the link to the evaluation in the chat. Please fill it out. Whether or not you want credit, we'd love to hear from you. And yeah, thank you so much, Dr. Gibson, for coming and giving us this presentation. This was a fabulous webinar. So everyone, have a great afternoon. And maybe we can have you back for a follow-up.
Thank you.
All right. Thank you. Everyone have a great afternoon. Thank you, Dr. Gibson.